Jon Weissman. Jon is a retired labor community organizer in Western Massachusetts and the former coordinator of Western Massachusetts Jobs with Justice, a coalition he helped to found in 1993. Jobs with Justice builds local coalitions of labor, community, student, and faith-based organizations in the struggle for workers' rights as human rights. He started off in the post office in Springfield, Massachusetts during the Wildcat strikes in 1970. He's a former Postal Service letter carrier, president of his union, the National Association of Letter Carriers, Branch 46, secretary treasurer and trustee of the Pioneer Valley Central Labor Council, now an assembly of the Western Massachusetts Area Labor Federation, and the Western Mass Jobs with Justice coordinator. He guided the merger of Western Mass Jobs with Justice and Eastern Mass Jobs with Justice in 2017 and formed the overall Massachusetts Jobs with Justice coalition. In retirement, quote unquote, he is a co-convener of the Western Mass Medicare For All and Western Mass co-chair of MassCare, the Massachusetts campaign for single-payer healthcare. So with that impressive resume, please welcome Jon Weissman.
Thank you, Peter. Thank you all for inviting me. Very much appreciate the opportunity to talk about the Massachusetts campaign for single-payer healthcare, nicknamed MassCare. Special thanks to Stefan for giving me prompts for my talk. And I do apologize in advance that I have to leave right after my Q&A. First, though, I want to make sure you are watching New York. You're also watching New York, especially in California. I'll put links in the chat to those two campaigns. As you know, many other states too have some version of a campaign for a state-based single payer. But the question comes up, doesn't single payer only work on a national level? The answer I would give is yes and no. Yes, the goal is a national system, but given the size of single payer nations around the world, it can be done efficiently with a smaller population. We think Massachusetts, for one, the smallest of those three, can easily pull it off with a massive savings estimated at something like a quarter of our current spending. In fact, the folks in the state single-payer movements see themselves as part of the national movement, whether because of the Canadian story. We like to say that New York, California, Massachusetts are competing to be the Saskatchewan of the United States, or the laboratories of democracy argument, or the stories of so many reforms, including the New Deal and marriage equality. We have a board member who likes to say synergy. The Affordable Care Act does provide for waivers for state alternatives, and Representative Rokana has filed a bill to improve that provision. So I'll put the link to that in the chat. I think the political realities in DC versus realities in Boston, Albany, Sacramento. You tell me if Hartford should be on the list. The problem in DC focus most grassroots single-payer advocates on a state solution. If the campaign has a strong bill, good grassroots organizing strategy, and legislative optimism. One of the grounds for legislative optimism in Massachusetts is the veto-proof supermajority of Democrats, members of a party that has single payer in its platform. But of course, there are grounds for legislative pessimism. I won't dwell on those right now. Let's be upbeat. So the Massachusetts bill would establish the Massachusetts Healthcare Trust, a single payer of all medically necessary healthcare costs of state residents, note residents, not citizens, incurred at practitioners who may not accept payment from other sources for services provided for by the trust. To find the wherewithal to pull this off, the trust collects the dollars that most federal programs would otherwise spend, including Medicare, but that won't be enough. So there are taxes to raise the rest of the revenue, currently being paid as premiums, deductibles, co-pays, and co-insurance. I'll give you the list of taxes. Not too onerous. You can see that on the payroll tax, the lion's share is paid by the employer. Large employers pay a little bit more, but everyone gets a $20,000 exemption to start, and employers can pay 100% of the tax, and there will be some amount of competition to do that to attract workers. So a good bill includes this financing. That's one place that Vermont went wrong. This bill is identical in both houses of the legislature. It was originally written by MassCare, and every 2 years, MassCare leads a review process with legislators to improve the bill. A Senate version of the, let's get that hyperlink. You're seeing it on the screen, and here's a link to it. This was created by Senator Eldridge, our lead co-sponsor in the Senate. For the first time in 24 years, this bill has been around for 24 years in some way, shape, or form. For the first time, the bill has a caucus within the legislature, led by the lead co-sponsors of the bill, open to all co-sponsors who pledge to do public events in their districts. MassCare and its various grassroots parts can provide the person power to pull off those events. So we work backwards from victory. And to express that, we've created a strategy statement that I'll give it, the link is now in the chat, just so you can get a sense of a particular dilemma that the movement faces, which is, of course, you won't be able to read it in the share screen, but you'll see it's not too long, but it's addressing this question of whether it started off by addressing the question of whether or not we should do a ballot question. There's two ways that laws become enacted in Massachusetts: a vote of the legislature during a 2-year session, after which it dies, or an initiative petition placed on the ballot by the people, voted statewide in a general election held in even-numbered years. And Massachusetts progressives have been so successful with the ballot question campaign that there's some tension. We wrote this in order to reframe the question. Both paths present opportunities and difficulties. Both paths we have great experience succeeding at, but neither path can succeed unless a massive statewide grassroots organization is built, especially given the opposition to this massive change in our economy. This organization must be based on the broadest possible basis of all people, Black, white, Latino, Asian, Native American, who are affected by the high cost and in many places the inaccessibility of healthcare. We've designed our grassroots organizing around two formations: legislative districts and leading organizations such as labor, healthcare, community, faith-based, business. A hub, we call it a hub, is our basic unit of grassroots neighbor-to-neighbor outreach and education. Our goal is to have 160 hubs. That's one for every state representative district, carrying out effective organizing work. Of course, each state rep district is entirely or partly in one or more of the 40 Senate districts. So there can be more than one hub in a district, and if so, these hubs should coordinate their organizing and lobbying. And one hub can also cover more than one district if they have the capacity. A hub can be a group specifically created to advocate for single payer, or it can be part of a multi-issue organization. A hub's primary responsibility is to build support and mobilize within their district for our legislation. That means lobbying and, if need be, replacing state reps. We also work in collaboration with others regarding senators, state senators, and members of Congress. So hubs and organizations form what we call the MassCare Coalition. And the link to what you're seeing is here. It's slightly larger. That list is has grown since we last published it, and the reason it hasn't been updated is because we're moving to a new web platform, which will have better functionality. So these hubs and these organizations send representatives to what we call the Grassroots Organizing Committee. The nickname there is the GO, exclamation mark. The GO determines the campaign strategy and tactics. Each hub or organization gets one vote, but can send as many reps to the GO as they want. So far, it has never had to take a vote. 4 classic hub tactics are public educationals. In particular, they love to show Fix It. There's the link to Fix It. By now, I'm sure you're all familiar with it. And be sure to tell people they can watch it for free at their leisure, but we have done a lot of public events with it. Another tactic that's popular is delegations to legislators, of course. Resolutions, both municipal and organizational. So that would include organizations like I mentioned before, labor and other organizations, but also town, ward, and city Democratic Party committees. And then a fourth, which I know Stefan was interested in, is non-binding ballot questions. So we have this ability in Massachusetts to run ballot questions that are only in the representative district, and they are only advisory, but in a couple of instances, they convinced a representative to co-sponsor our bill. There's a low number of voters, only 200 are required to petition to get it on the ballot. We first started doing these in 1998. I forget how many total we've done, but we have yet to lose in any district. In 2018, not only did the ballot question win in each of 6 state rep districts where it was on the ballot, it won in every town in those districts, with some support as high as 89%. So obviously we could come back to that in the Q&A. The rest of the MassCare structure is a 501c4 board of directors and its committees, and a 501c3 educational arm called the United Healthcare Education Fund, or USEF. USEF's officers form its board and are also members of the MassCare board. The MassCare board is currently 22 people. It's an activist board. At least 6 are required to be representing organizations. We've gotten that number up to 9, plus others, other individual board members have strong organizational ties and organizational experience. Our committees are led by and mostly comprised of board members. They are fundraising, communications, education, and membership, what you would expect. The Grassroots Organizing Committee and the new Labor Committee are technically board committees. But when you look at them, they look more like coalitions. Annually, we elect a Western Mass and an Eastern Mass co-chair, a secretary, and a treasurer. Using a doctor's bequest, MassCare used to employ a full-time director. Currently, we can only employ a half-time organizer, office manager, and a new one just began yesterday. So the original outreach to me came from Stefan through in my role at Western Mass Medicare For All. So I'll just quickly tell you that it functions as a MassCare hub, but because it is regional, all 4 counties of Western Mass, and it takes responsibility for all 27 Western Mass legislators, it becomes also a hub builder, and it also does more than hub building. It originally innovated the hub strategy and brought it to MassCare. And in similar fashion, it innovates around other kinds of organizing projects and forms of education and how to do outreach with community groups and whatever. So we like to think of ourselves as pathfinders and then trying to scale that up statewide. And another version of that in Western Mass is our new Western Mass Area Labor Federation Healthcare Committee, which innovates around bringing the labor movement into the single payer movement. So I do want to especially refer you to the Western Mass Medicare For All resources page. Of course, while you're there, you could spend some time on the other pages of the website. We expect this kind of regional structure repeated in other parts of the state because it's a state that classically is divided into regions, almost balkanized. So I'm going to end it there and see what the questions are. Thank you very much for the time.